guess we'll get started while I fiddle around with these people in the waiting room. I guess I'd like to welcome everybody to our, I'm not sure, fourth, fifth drop-in meeting, and especially Dr. Ling. Dr. Ling is a pediatric hepatologist at a hospital for sick children in Toronto, and is also on the Alpha-1 Canada Medical Advisory Board. He's going to talk to us a little bit about pediatric Alpha-1 liver disease, which of course is unique to a lot of us who are on the line now who are suffering from the lung version, if I can call it that. Although I think we do have a couple of parents online right now, so just want to let everybody know that we are recording this event. We are having difficulty trying to figure out how to load those recordings onto our website. So you can either just use your first name to protect your privacy, or I mean, if you want to call yourself Yogi Bear or something like that, that's fine too. So I think without further ado, and I think Simon's got a fan online too. Dr. Cox is listening in. So I guess I'll turn it over to you, Simon. You can spend maybe about half an hour with your presentation, and then we'll open the floor up for questions. So, Dr. Ling, thank you.
Okay, thank you, Jim. Thank you for the introduction, and it is very much a pleasure to have this opportunity to join your group and to spend some time sharing with you what is my impression of Alpha-1 antitrypsin deficiency as being from a pediatrician's point of view, really. And I think a lot of what I'm going to talk about is related to liver disease and the experience that I have had here at the Hospital for Sick Children, caring for some of the children that are affected by this disorder. I'm going to touch just very briefly at one point on lung disease, but when I do that, I'm going out of my area of expertise. So that's my first disclaimer. The second disclaimer is that as with any disease process, it affects different people differently, and any individual circumstances are unique. So everything that I say, I think, needs to be carefully interpreted and ideally discussed with your own physician if you're attempting to apply what I'm going to say to your own or your child's circumstances. So that's my brief disclaimer. Now, what I was asked to do is to talk for about half an hour, and I'll just outline the things that I want to cover. The bulk of this is clearly going to be about with Alpha-1 antitrypsin disease, and I'm going to talk about the liver involvement and a little bit about lung involvement. I'm going to talk about mechanisms by which liver problems arise, and then I'm going to move on and discuss some of the issues around management and the kind of lifestyle advice and how to apply that to children, which is probably one of the biggest challenges, I guess, is adapting advice around how you live your life so that kids can apply it to their lives. So that's the outline of what I'll talk about. Children with Alpha-1 antitrypsin deficiency are nearly all asymptomatic, well, healthy children who have no obvious problems arising from their condition. And that is an important context in which to place some of the things that we're going to talk about subsequently when we come to discuss the kids that get problems. They're very much a minority group amongst children who are affected by Alpha-1 antitrypsin deficiency. So the liver problems, which form the bulk of those kids that do get trouble, for many will not cause symptoms or problems with how these kids can live their lives. So the biggest group of these kids are those who are found coincidentally to have some slight abnormalities on their blood work. There is an interesting group of babies that get jaundice, and that's because of the alpha-1 antitrypsin deficiency, and I'll talk a bit more about those. And then there is a small group who might progress to get more severe liver disease that does become a big health problem, and I'll talk a little bit about that as well. So what about babies and jaundice? Most of you will know that jaundice babies are common, and usually that jaundice is normal. It's just part of being a baby. It might relate to the breastfeeding and the maturity of how the liver has developed at the point where the baby is born. Not everything's working at full capacity at that stage in the baby's life, and so a little bit of jaundice is common. But there are two types of jaundice. There's the normal type, and then there's an abnormal type, which suggests liver problems. And we can determine the difference between those two by looking at the jaundice in the blood more closely. So jaundice is caused by bilirubin, which is a chemical in the blood, and it can be either unconjugated or it can be conjugated, where the bilirubin is stuck to another molecule. And if the liver's not working properly, then it's the conjugated bilirubin that we look at. So most jaundice babies have the other kind of jaundice, the unconjugated jaundice. But if we find the conjugated bilirubin in the blood test, that tells us that there's probably a problem with the liver. And we have to check out the baby to see if they have some form of liver disease. And what we embark on at that point is a stepwise process where we work through a list, which the last time I tried to list all the possible causes, I got to about 40 possible causes of this kind of abnormal jaundice in babies of a few weeks of age. And by going through a process that starts with getting the story, examining the baby, doing a variety of blood tests, doing some scans, ultrasound scans in the person, we can work through and pick off lots of these conditions fairly quickly usually, and home in on what might be the more likely causes. And they include infection, they include a blockage to the bile duct, and they include various genetic or metabolic problems. Alpha-1 antitrypsin deficiency is one of those conditions, and we reach that diagnosis usually after ruling out lots of those other conditions. And typically that diagnosis is made by blood tests. Sometimes a liver biopsy is done, mostly to look for other conditions. And when done to look for other conditions, we might find on that liver biopsy some evidence of alpha-1 antitrypsin deficiency, which makes the light go on and we say, aha, this is possibly what's the problem here. So the diagnosis is more typically reached by doing the blood test, looking at the type of alpha-1 antitrypsin protein that's found in the blood. And that's where we maybe ask Dr. Cox and our colleagues to help us by looking at the type of protein, and sometimes also by looking at the genes. And I know that Dr. Cox talked on the last one, I think, of these calls about the genetics of alpha-1 antitrypsin deficiency. So through going down that route, we end up with an understanding of what is going on with a baby's liver. Hopefully we rule out lots of other conditions, and sometimes we end up with a diagnosis of alpha-1 antitrypsin deficiency. in those children, most of these babies will see an improvement in their jaundice and few other problems arising during the first weeks or months of life, and things will seem to get quite a bit better. So rarely we can see some of these children progress to develop more important liver disease. And the proportion of children that might develop significant liver disease is probably somewhere in the region of 3 to 5% of all affected children, and that figure is derived from this famous Swedish cohort study in which large numbers of newborns have been followed now for many decades. The progression to more important liver disease is therefore unusual, and often it will be picked up mostly by the medical team monitoring the child's progress as they go on from initially being picked up with jaundice in the newborn period. Sometimes progressive liver disease might develop without that newborn problem, and then there may not be close monitoring happening if nobody knows that the child is affected by any underlying condition. And then it may be that symptoms or other problems have to develop before the liver disease becomes apparent. So maybe the child will develop non-specific signs like a lack of energy, or failing to grow and keep their weight going up adequately, perhaps becoming jaundiced, although that would be quite an unusual way for this kind of liver problem to present itself. Sometimes the child might visit their pediatrician or their family doctor for another reason and have their tummy examined by the doctor, who will find that there's a large liver or a large spleen, and things become apparent through that. And then the changes in blood work and perhaps on an ultrasound scan can identify that there is a more significant liver problem going on. And in that setting, the usual process would be to get referred to a pediatric gastroenterologist or hepatologist for things to be looked at more closely and for further monitoring and treatment as required. And I'll come on to that a bit later. So, as I started out by saying, most children with Alpha-1 antitrypsin deficiency have none of those problems, and instead remain well and without symptoms. But if blood work is checked, you may find that there is a slight increase in the liver enzyme numbers in the blood work, that is the ALT and the AST, which show that the liver is just being irritated a little bit by something. And that is a very common finding among children with Alpha-1 antitrypsin deficiency. Depending on which group of children you choose to study, and there have been a few groups that have been reported in research studies, the frequency with which liver enzymes are found to be abnormal ranges from about 1 in 10 to more than 50% who are found to have slight abnormalities of the liver enzymes. We think that most of these kids, their liver does not become a problem. This low level of irritation can continue without causing great trouble. But once these abnormalities are found in the blood work, it's probably wise that somebody just keeps an eye on them. And again, I'll talk a little more about monitoring and treatment later on. So, to do with the liver, what about the lungs in children? I think it's standard teaching that the lung problems related to alpha-1 antitrypsin do not become apparent during childhood. So most children do not have significant lung disease problems in spite of alpha-1 antitrypsin deficiency during their childhood. Some studies, however, have shown that there's an increase in symptoms of asthma. And if people have looked at lung function through lung function studies, in older children at 18 years of age, there are changes becoming apparent and detectable by that age in those teenagers who have been smoking. And that difference is fairly clear. And a little more controversial is that in that age group, the 18-year-olds, there may be some changes apparent in children whose parents or other household contacts have smoked, so that they've been exposed to secondhand smoke during the course of their childhood. So there's a suggestion that there's a change that can be detected at 18 years in those children. So what about the mechanisms by which liver disease developed in alpha-1 antitrypsin deficiency? And I want to just discuss this briefly because there is an important difference between the way the lungs become diseased and the way the liver becomes diseased. The protein, and I think all of you on the call are probably fairly familiar with the idea that alpha-1 antitrypsin deficiency creates an abnormal protein, an abnormal alpha-1 antitrypsin protein. And in the liver cells where this protein is made, the protein doesn't get out in the normal way into the bloodstream. And the problem is all to do with what happens to the protein after it's been made. So the post-production processing. It's a bit like making movies. So if I made a movie, rather than Steven Spielberg making a movie, the post-production team would have to do a lot more work on it than they would if Steven Spielberg had made it. So I've made a pretty bad movie, and the post-production people have got to try and turn that into a decent movie. And they've got a lot of work to do, and they maybe won't be able to get it looking as good as it needs to. Now what you hope is that their boss is going to say, this is a terrible movie, let's just bin it and get rid of it. But if their boss isn't very good at making decisions like that, then things get stuck. And the movie never comes out, and the post-production people get caught up in continuously trying to improve it. So in the liver, if you make an abnormal alpha-1 antitrypsin protein, the problem is in the post-production processing. It gets stuck, it can't process properly and send out into the bloodstream, and it builds up and accumulates in the liver cells. And the liver cells don't like that. And perhaps if the process in your liver cells that should get rid of that problem protein isn't working so well, then the abnormal protein builds up even more, and the liver disease doesn't like it even more. And then you develop some liver disease. So in the liver, the problem arises because of too much of this abnormal protein stuck in the liver cells. And that is clearly very different to the lung problem, which is not enough of the normal protein coming to the lungs to help deal with the inflammatory problems that might go on there. In the liver, we get this abnormal stuff in the cell. It irritates the liver cell. That creates inflammation. And the inflammation that goes on over time ultimately causes scarring in the liver. And that scarring might never get bad, but in a small number of people it can get bad, and it can progress and create a lot of problems with liver function. So that's the kind of mechanism that gives rise to liver problems, typically in children with liver disease, in my experience, but also sometimes in adults with alpha-1 antitrypsin deficiency as well. One of the questions that always fascinate doctors who think about these sorts of conditions is why do only some people get the problem? So in terms of liver disease and alpha-1 antitrypsin deficiency, I mentioned that perhaps somewhere between 3 and 5% of children with alpha-1 antitrypsin deficiency develop liver disease. So why is it only those ones and not everyone else, when on the surface of it, they seem to have the same genetic problem? And the way that is sometimes explained relates to other things that are affecting how well the cells can handle the problem. And that might be genetically determined, or it might be other things in the environment, infection, other toxins or irritants that upset the liver, for example. So this is an idea that I wanted to mention around genetic modifiers, which are factors in our genes that change how we cope with different stresses and strain. They're not mutations that cause clear abnormalities, but they might influence how well we can deal with an abnormality such as alpha-1 antitrypsin deficiency. We've also had an interest in whether being a carrier for alpha-1 antitrypsin deficiency, so having one mutation rather than the 2 mutations that we think you need to get disease problems, whether that can itself be a modifier for other liver problems. So that if you have another cause of liver disease, maybe you get more problems from that if you're also a carrier for alpha-1 antitrypsin deficiency. And that's something that there's a little bit of evidence starting to appear in children related to other liver diseases that some groups of children get. And we have some work going on about that area, which I can talk about later if you're interested. So in the last 5 to 10 minutes, what I'll turn to now is management of children with alpha-1 antitrypsin deficiency. And what I'm really focusing on here is the liver problems. And as I've mentioned, the way that the liver problems arise with the abnormal accumulation of the protein, what I think becomes clear from that is that giving the normal protein doesn't necessarily solve the problem. So giving alpha-1 antitrypsin replacement therapy, we do not think is likely to be effective in helping liver disease in children or adults with alpha-1 antitrypsin deficiency. I think what there are to talk about, though, are what sort of advice we should give and encourage our children to follow in terms of their lifestyle. How might we monitor those children who seem to have some evidence of liver problems? And I'll just touch upon some of the issues and complications of more important liver disease that we might sometimes need to try and manage. So the lifestyle advice is, I think, the most important of these management issues. And top of the list here has to be to avoid smoking. We clearly need to instill that in all our children, and especially those who have alpha-1 antitrypsin deficiency, so that we can try to minimize their future lung problems. I think in addition to that, we want to stress the importance of avoiding secondhand smoke and other environmental lung insults. in terms of choice of career, etc. On top of that, one of the questions I'm frequently asked is related to diet and liver problems. Is there a diet that I ought to take, or is there something in my diet that I ought to avoid that's going to help my liver disease? The answer here is somewhat of a general one. So first of all, I do not think that there's a specific dietary ingredient that you can take excess of that will help liver disease, whether it's due to Alpha-1 antitrypsin deficiency or anything else. What I do think helps, although this is a difficult thing to prove, but what I do think helps is a good varied diet. So a diet that follows the recommendations that you can get from Canadian government or many other sources that tell you how much fruit and vegetables you should have in your diet, how much meat you should eat, etc. So a good varied diet is a great target to aim for if you have what's usually a low-grade liver problem that you want to avoid getting worse. Of course, achieving that is something else when you're dealing with perhaps a preschool child who might have very firm ideas about what they consider to be a balanced diet, or a teenager whose balance is between pizza on a Thursday and burgers on a Friday. So achieving it is a goal that I have only limited help that I can give there. As a father of 3 kids who have very varied eating habits of their own, I know how much of a challenge that can be. Now, what I also wanted to touch on is the issue of teenagers and the advice that we should be giving to our teenagers as they make the transition to independent adult life. I think the dietary advice that I've mentioned becomes very important to continue to stress that. Although they might appear not to be listening to us, we do know that our teens listen to their parents, and that the advice that they get from their parents does feature significantly when they're making decisions about how they're going to live their lives. So it's clear to me that even when you feel that the teens aren't listening, they are listening, and they are going to factor in what you're telling them into their decision making. And that is very important when we come on to talk about alcohol. So if you've got a low-grade problem that's irritating your liver, it is my belief that if you add another low-grade problem that also irritates your liver, you might run into trouble a bit quicker than you would if you only had one problem. And this is where the question of what do you do about alcohol on top of liver disease comes in. If you have a liver problem, how much alcohol can you drink safely to avoid trouble down the line? Now, I don't believe anyone has a clear-cut, evidence-based answer that they can give to that question. But there's some common sense and logic, I think, that can be brought to bear here. And we have to introduce a dose of realism as well, I think. But in terms of dealing with the kids as they grow through their childhood and into their teenage years, I think it can be helpful to instill the idea with them at an early stage that they would do well to see themselves as someone who's not going to drink alcohol in the future. And that, I think, can go a long way to addressing expectations as the teenage years come on. It's clearly much more difficult to say to an 18 or a 20-year-old who's got into the habit of drinking alcohol regularly that they have to stop, rather than having someone grow up with an expectation that they're not going to drink, or they're only going to drink very rarely. My concern is that if I'm talking to a 15-year-old, what I'm wanting to do is put them in a situation that will allow their liver to keep working adequately for their knee for the next 80 years. And to do that, we need to make sure that those little irritations to the liver are kept to a minimum. So that's what I try to explain to these teens, and I hope that they listen. I try to encourage the idea of not drinking regularly, of not drinking to excess, even rarely, and seeing alcohol as something that if they want to take it, they can take it on an occasional celebratory day. Now, alcohol for some of our teens these days is perhaps one of the least innocuous substances that they have available to abuse if they should choose to. And my advice to teens that I try to proactively give them before they come asking is to avoid other kinds of recreational or street drugs, many or most of which are dealt with by the liver and have a great potential to harm the liver. So that's a fairly clear and I think fairly easy piece of advice to give. We encourage the teens that they grow from childhood through their teenage years to gain information about the disease. We try to give them that information and give them sources where they can find other information. And we encourage them to take control over the management of their problem so that as they develop independence in other areas of their life, they also learn how to deal with the healthcare system, how to talk to doctors, and how to get the most out of their visits to clinics. With regard to that, there's a program that's been developed by some of the people here at Sick Kids who have taken this issue of transitions from childhood to adulthood as their specialist area, and they've put together a great program that they've called Good to Go. And there's a whole variety of different aspects to this Good to Go program, many of which is available through the Sick Kids website. Maybe Jim can help and I can distribute an address to anyone that's interested in that, which is a useful resource, I think, to anyone that has kids that are moving through this sort of process. So I should probably finish up before too long, so I was going to just touch upon the idea of monitoring of problems, which really amounts to occasional blood work and perhaps an occasional ultrasound scan for those people that have ongoing liver problems that one might be concerned could become worse with time. And finally, and I might leave this unless someone has questions about it and I can come back to it, the issues around management of complications of the more severe liver disease and Alpha-1 Antitrypsin deficiency, which really applies just a very small group of children where we have to take more particular attention to their dietary requirements, to certain vitamin deficiencies, and to some of the symptoms that can arise from more advanced liver disease. As I mentioned, I can come back to that if anyone would like to ask me a particular question about that. So, in closing up, I would say that most kids with Alpha-1 antitrypsin deficiency are going to be well. They're not going to have symptoms. They won't have significant liver problems, although you might be able to find a little bit of irritation there if you go looking in the blood test. And their respiratory problems during childhood are going to be absent or minimal. The important issues, I think, are watching out for the small number of affected people who will develop problems. The importance of lifestyle advice to children as they grow into their teens and adulthood, and managing that transition to what we hope will be equipping them for a healthy adulthood, during which they can deal well with the healthcare system and any problems that they may face during their future adult life. So I will finish with that and invite any questions and do my best to answer them.
If anybody wants that information about Good to Go, I've got it here in front of me. Just stay on the line afterwards, and I'll pass it on. So, do we have any questions?
This is Ken. I have a question. What are some of the symptoms one might experience with liver problems?
So if you're going to get symptoms from a liver problem in which you have a long drawn-out, low-grade irritation in the liver that has perhaps led to a build-up of scarring or what we call fibrosis inside the liver, then the symptoms tend to be vague symptoms. So a loss of energy, perhaps a loss of appetite, some people occasional vomiting, and those would be the early symptoms, and clearly they can be arising from a number of different sources and may have absolutely nothing to do with liver problems. If a liver problem of this sort goes unrecognized over a more prolonged period of time, then eventually more significant things might happen. You might start to turn yellow, which tells you that the liver's not working properly, and in that situation, that should become very obvious to you when you look in the mirror. You may develop a distension of your abdomen. You may develop a dragging, uncomfortable, painful feeling in your abdomen related to swelling of the liver or swelling of the spleen. And then ultimately, if things get significantly bad, you can have accumulation of fluid inside the abdomen, which creates even further distension, and sometimes bleeding from the intestine, which can present with blood in a vomit or in the stools. So those last set of symptoms would be indicative of quite severe liver problems that, in the context of Alpha-1 antitrypsin deficiency, would have gone unrecognized over a fairly prolonged period of time.
Thank you.
This is Alison. And I just have a question about, you mentioned avoiding environmental lung irritants as they grow up. Is there any research, I know there wasn't at one point, I don't know if there's any more information on environmental in terms of smog and air pollution and the effects of that?
Yeah, that's a great question, and I would say that I'm not aware of any conclusive evidence that would say that respiratory health specific to children growing up with Alpha-1 antitrypsin deficiency is better if they live outside of a smog-laden city compared to within a smog-laden city. I think there is an amount of research on this area in terms of the general childhood population, which raises interesting questions about how bad asthma is in cities versus the countryside, etc. But it's not a simple equation, because there are irritants that can affect the lungs of a different sort out in the countryside. So I think that my understanding would be that there's not clear-cut evidence to answer that question with. It's an important question for children with Alpha-1, but I think one at the moment that doesn't have a clear answer.
Thank you.
Dr. Ling, there was an article on our newsletter today, and really just a little short article that referred people to some research that was done at Baylor College and the University of Florida, and where they've found a checkpoint protein that may hasten the onset of liver failure in infants with Alpha-1. Are you familiar with that research? Or
no, I hadn't seen that. Do you know what the protein was?
I'd have a really hard time pronouncing it. It's the mannose molecule, which removes mannose from the protein to market for degradation and removal from the liver.
So I think this is an interesting area that there's going to be more studies looking at what we call modifiers that might encourage the development of liver disease in Alpha-1. And there's going to be similar studies in a whole variety of different diseases. These are difficult studies to do well. And not being familiar with this particular study, I can't comment on the detail of this one. But I think it's an area that we've seen a lot of work on in a variety of diseases over recent years. A lot of the studies are a bit too small, and sometimes patient groups that are included in the studies are not quite as well defined as you might hope. So you can't be as certain as you'd like to be that you're really dealing with the disease in the way that you think you are. So they're challenging studies, but they are throwing up some interesting findings in a variety of diseases about genetic factors that might influence how severe a disease becomes for an individual. We have been looking at the crossover between another gene, which is the gene that causes cystic fibrosis when there's a mutation in it. And we've been looking at the relationship between cystic fibrosis mutations and Alpha-1 antitrypsin mutations. And we've been looking at it in both directions, because when you look at children with cystic fibrosis, interestingly, about 7 to 10% of those children get bad liver disease. And so a situation that's kind of analogous to the Alpha-1 antitrypsin deficiency situation, where only a small proportion get significant liver disease. And when we looked at a large group of children with severe cystic fibrosis liver disease, we found that a lot of them had the carrier state for Alpha-1 antitrypsin deficiency. So they had one mutation, not two. And normally we would expect that not to cause trouble. But in the setting where you've also got cystic fibrosis, it seems in a proportion of these kids to encourage their livers to get bad. So then we flip that coin over, and we're in the process now of asking the other questions, which is, if you have Alpha-1 antitrypsin deficiency and you have liver problems, might it be because you are a carrier for the cystic fibrosis gene mutations? And we're in the process of collecting up as many people as we can find who are willing to be involved in that study and give a sample of DNA to allow that analysis to take place. We looked very early on with just a small number of patients and found quite a positive association, but it was very early and only a very small number of patients, so certainly not a situation where we can say that we've shown a significant finding yet. But it encouraged us to continue to try to grow the study and grow the number of people involved with the study. And certainly if anyone on the call is interested in hearing more or potentially becoming involved in that, again, I can give a contact email, perhaps through Jim, and you're welcome to contact us.
That'd be great. Jim could probably put it on the website as well.
Great.
That would probably help, Dr. Ling. Maybe if people would see it there, it may remind them.
Yeah, that'd be very helpful.
Okay. Any further questions?
I do.
That's right.
I heard a speaker, and I wish I could remember his name, at the Alpha-1 Association conference last year, and he was talking about research that's being done, I guess, perhaps, if I'm not mistaken, maybe even by him, but looking at sort of the issue of the polymers of Alpha-1 building up in the liver, and that they were looking at, I guess two options, and that was one of some way to degrade these polymers so they can pass, I guess, and the other was to introduce, I guess, because of the way the Alpha-1 antitrypsin protein, because the way it is misfolded, it's I mean, it's kind of like Velcro, which is they bind very nicely to each other because of the misfold, and sort of build up, and they're looking at sort of introducing something that might fill that gap so that there's no longer those sort of hooks and loops, I guess, on the outside, so that they wouldn't build up and perhaps would be more likely to escape the liver, I guess. Are you familiar with any of that kind of research, or whether I remember him talking about it, and I don't remember how far along or whether it looked promising or not.
Yeah, I think that this is another area in terms of the hope for future treatments that has some promise, but also lots of challenges. So this is the area that I was talking about, this post-production processing, and it's clear that the common version of Alpha-1 antitrypsin deficiency with the Z protein can create these polymers that you've very nicely described, in which they get stuck together. So each individual molecule of the protein takes up a funny shape that just fits into the next protein, and they get stuck together in sheets. And it is those sheets or polymers of protein that accumulate in the liver cells and seem to give rise to this irritation. So if one can find a way of enabling the cell to deal with that protein better, one might be able to avoid the liver problems arising. So at least if you could encourage the cell to get rid of that abnormal protein, destroy it, so that the stimulus for the irritation was taken away, you might avoid some of the liver disease. And at best, you might be able to encourage the cell to make up for the abnormality of the protein and manage to push the protein out into the bloodstream, where it might be able to be effective to an extent that could also help with the lung problems. So that would be the sort of best case scenario if one could come up with a treatment that could achieve that. There has been some work looking at molecules that might be able to impact this process in one way or another. And at least one of them has the ability to be given to humans without causing obviously large amounts of trouble. And that's always the problem. First of all, can you come up with a treatment that can be taken and that can arrive at the place where it's needed inside the cell in a way that is feasible, so ideally by taking it by mouth, and in a way which doesn't cause enormous amounts of side effects. So I think this is a process where there is work going on. I don't believe that it's yet reached a point where it's going to be imminently applicable to human studies, let alone widespread clinical usage. But I think it's an area that holds hope for future therapy. There has been a lot of talk over the years about gene therapy, and it's clear that gene therapy is going to be a much harder hurdle to overcome than anyone anticipated. And I think people anticipated it was always going to be difficult. It's proven to be really difficult for many of the conditions where we really would like it. In contrast to that, perhaps the option for these kinds of therapies that might interfere with the post-processing problems and make that passage of the protein a little more smooth, that might hold more hope in a sort of realistic sense for future therapies, although I think nothing just yet.
Is there any other research that's perhaps further along that is looking towards, I don't know, I mean, I know we're a long way from a cure, but of helping especially kids with the liver issues, or is transplant really still the only viable option right now?
I think for that very small number of kids that develop end-stage liver disease, where the liver has really got to the extent where it just can't work properly anymore, transplant is the option for those kids. And I think we would all hope that one day we'll have a treatment that will be able to avoid that from happening in that small number of kids. But at the moment, I don't think we have a treatment or anything that's imminent that will be effective enough to help that sort of group of severe children.
So in those small number of children who do receive transplants, are they effectively cured?
They are effectively cured of their Alpha-1 antitrypsin deficiency because the new liver will be able to make the protein. What we say to anyone who's needing a liver transplant for whatever reason, the issues that can arise after you've had a liver transplant are fairly significant for some people. Fortunately, it often goes well, but there are clearly issues that you then have to live with that are different to the ones that you were living with before the transplant. So the idea of a cure is a little bit of a falsehood, really. And what we sometimes describe it as is swapping one disease for another. And we would choose to do the liver transplant if we thought that either the first disease was going to ultimately, or even imminently, I guess, in this situation, be a fatal problem for you. Or we would do it if the problems that you're living with before the liver transplant are significantly worse than the ones you'll need to live with after the liver transplant that arise simply because you've had a liver transplant. So the medications that you have to take after transplant to suppress the tendency to reject the organ can create problems of their own, and that's the sort of thing that you have to then live with after you've had the liver transplant.
Right. Are there any other questions?
I have one. Just trying to understand all of this. When the misfolding occurs in the liver and creates cirrhosis or whatever damage, scarring, is that usually throughout the whole liver, or is it start in a segregated spot and then continue to grow?
By and large, it occurs throughout the whole liver, and it starts mildly at a level where you need a very powerful microscope to show the beginnings of the scarring starting to be laid down. And in many people it'll stay at that kind of level, or it might get a little bit worse, but it won't continue to get severe. In some people, perhaps because of this idea of modifiers elsewhere, perhaps their tendency to produce scar tissue is greatly enhanced by just the way they're made up in other respects. In some of these people, the scarring progresses throughout the liver and ends up as something that you can see with a scan, for example, and which is very obvious and very much a problem.
I was just wondering, because the liver can regenerate itself, if those smaller segregated spots were starting, why they couldn't remove those.
Right.
It would be ideal, wouldn't it?
It would. It would be a great way of...
Well, I guess in that case, we'll thank everybody for joining us. And the Good to Go program is at www.sickkids, all one word, SICKKIDS.ca / the one underneath the question mark, good, the number 2, go, another / and index.html. I think I might just write an article for an upcoming newsletter on that program, so hold tight if you don't find it. Once again, thanks everybody for joining us, and hopefully we'll see you next month.